So welcome back. We're excited to get started on our next session. This panel will provide information on exploring intersectionality in injury prevention. I want to recognize Beatriz Manitou, Associate Manager for Injury Violence Prevention Section, for helping to pull this session together. The idea for this panel was generated to address the reality that people do not experience public health issues in silos or as separate issues. As a result, the analysis and prevention efforts that you'll hear about today and interventions need to be multidimensional and intersectional. Only then can we create responses that encompass the whole being and scope of experiences in the lives of the people we serve. Doing this work together, we can become more intentional in addressing injury prevention. We want to take this opportunity to highlight examples of how it is being explored at the Minnesota Department of Health to foster conversation across MIPA members. It is a pleasure for me to introduce our panelists for today. Caroline Palmer, the Interim Violence Prevention Programs Unit Supervisor in Minnesota Department of Health, Injury and Violence Prevention Section. Kelly Felton is the State Suicide Prevention Coordinator for the Minnesota Department of Health. Cory is an applied epidemiologist who provides data analysis and technical support for the Minnesota Department of Health's Violence Prevention Programs Unit and Perinatal Violence Prevention Team. Mary DeLaquil started at Minnesota Department of Health in 2015 and spent her time extracting death data for the National Violent Death Reporting System. Their full bios can be found in the Speakers tab in the event platform. You may ask questions using the session chat on the right of your screen, and we will leave time at the end to answer questions. You may also private chat presenters or panelists later as well. And now I'll turn it over to our presenters. Thank you.
All right, good morning, everybody, and thank you, Nichole, for introducing us. My name is Kelly Felton. I'm the State Suicide Prevention Coordinator within the Injury and Violence Prevention section. And I'm going to share a little bit with you about how we're doing some work to really focus in on how we can work on a shared risk and protective factor approach for suicide and substance misuse prevention. Before I dive into what we're doing, I want to just share how we got to the point of trying to do a shared risk and protective factor approach, really to share, and I'm going to put up my next slide here, what we learned during our planning process for the state plan. And so a couple of the things that we did through our state plan obviously was to start with looking at our epidemiological data, but we also took some time to do some listening sessions across the state. And we really wanted to hear what is happening and what can we be doing better to promote mental health and to reduce suicidal experiences. And one of the themes that we heard during our listening session was primarily that we have to stop doing things in silos, specifically when it comes to substance misuse and suicide. And so we heard from our listening sessions that people are doing self-medication. We have unhealed trauma, which are really those root causes of substance misuse and suicidality, and that our systems are really focusing in on either suicide prevention and mental health and or our substance use and misuse. And so because our funding streams was really what we heard, has really put up a lot of barriers. And so we put it into our state plan to really focus in on what can we be doing to do this more shared risk and protective factor approach and explore it. And so how we threw that into our state plan was really trying to say, how do we increase collaboration with cross-sector partners to include those working on promoting wellness and mental health and reducing suicide, substance use, and adverse childhood experiences. One of the things that we knew through our listening sessions, as well as all of our work, is that there's a lot of people doing work around adverse childhood experiences, mental health, suicide, and substance misuse. And a lot of our communities were telling us that they're becoming, collaboration poor, but resource rich. And so really trying to figure out how we can collaborate, not only at the community level, but also from the state funding level to say, how can we do this a little bit different? What we know from research is that a lot of the risk and protective factors, specifically with substance misuse and suicide prevention, overlap. And we have been saying it for years and having the same conversation of saying, yes, we know that they have these shared risk and protective factors, but what does that actually mean and look like in practice? Knowing that a lot of people that are working on substance misuse prevention are funded under grants that don't necessarily allow for you to work on mental health. And for like the suicide prevention, as we continue to move more towards upstream factors that we want to address, that's going to look different as well. And so what we have really tried to do is start with just saying like there's a lot of benefits for us as we start to think about putting together a shared risk and protective factor approach, knowing, especially in rural Minnesota, it's oftentimes a multi-sector approach, which is what we are doing, is going to end up having the same people sitting around the table. And that's kind of why we said there's a lot of collaboration poor, where a lot of communities were working on ACEs in mental health and suicide prevention, but they were doing it separately because of their funding requirements. And so this conversation started to say, like, we need to start thinking about addressing these common factors so that we can maximize resources, so that we can talk about that we come as whole people and that we can't continue to compartmentalize all of the different issues that we want to address, and that communities are going to be so much stronger if they're doing this more shared approach. And so what we ended up having the opportunity to do is we were able to fund 10 communities across the state of Minnesota to do substance misuse and suicide prevention coalitions. So in both fields, coalition, multi-sector approaches are what they're encouraging us to do for best practice. And so we were able to find some braided funding between suicide and overdose prevention dollars to really say, like, how can we do this more upstream? And so these 10 communities all are focusing on youth ages 10 to 24. And then their goals are to build that multi-sector coalition to increase their community's capacity to be able to address these topics within their community, to go through a year-long planning process to understand what are the risk and protective factors that are happening within their own community, and really focusing in on strength-based approach. One of the things that we have really built in is talking about sustainability and making sure that we're being data-driven so that we can be culturally relevant, as well as making sure that once the funding is done, that the work doesn't go away with it. And then, so that's going to be like year one, is really trying to focus in on multi-sector, getting their capacity built, putting together their plan. And then years 2 through 4 will be where they implement strategies, including a lot of the policy, program, and practice changes to really, again, try to be more sustainable in the approach that we are doing. So how are we doing that? Here is like kind of the high level overview of how we're doing that with communities. So we meet with our community coalition coordinators on a monthly basis and bring them through the strategic planning process. The first 2 days were in person, where we really focused in on the public health approach, understanding why we're trying to do a community approach rather than working specifically with an individual approach, and then really giving them best practice around coalition work. We then brought in our Center for Health Equity to help us really center health equity in the very beginning and centered throughout the rest of the planning process. And then we had them go through a community asset mapping process to really say, what do we already have? and really build off of what's already there rather than just finding a gap analysis. And then we're in the process right now of bringing them through gathering data. And then as we get into the new year, we will be analyzing that data and then putting together some processes for understanding best practices, choosing those strategies, putting together a plan, and then really evaluating it to make sure that we know what is working within their community so they can make mid-course corrections if necessary. So that's a high-level overview. I do have my email address on here, and I'm going to send it over to Caroline for her to share a little bit about the work that she is doing as well.
All right. Thank you, Kelly. I do see one question here, but I'm not sure if we're waiting till the end for the questions that came to Kelly.
Yes. Yes,
Waiting
we'll
till
do all the questions at the end. Yes.
Okay, thank you. All right, good morning, everybody. My name is Caroline Palmer. Again, I'm the interim supervisor of our violence prevention programs unit here at the Minnesota Department of Health. And this unit includes our statewide responses to human trafficking and substance use. And so I'm going to briefly go over some work that we are doing looking at the intersections of human trafficking and substance use. Next slide, please. So our statewide response to human trafficking and exploitation is multifaceted. It involves many different state agencies, ranging anywhere from public safety to the Attorney General's office, human services, and beyond. And then also a wide variety of supportive services, regional navigator, tribal nation, and other grantees. And these are grantees that are focused on providing services to survivors of both sex and labor trafficking and exploitation. And the QR code that's on the screen will take you to the full map with all of the information about services in our state. Next slide, please. So just really want to take a moment here to highlight some of the vulnerabilities that are created by society that affect individuals who are victims and survivors of human trafficking. It's a lengthy list. As you can see here, it includes, among other things, exposure to other forms of violence, system engagement with juvenile justice, the justice system overall, foster care, people who are economically disadvantaged, or people who are with various race, ethnicity, sexual orientation, and gender identity groups. But the other thing I really want to highlight here is another one of the that affects people who are survivors of trafficking is the use of substances. Next slide, please. Various ways that substances are used in the act of trafficking and exploitation. For example, they may be used to groom, recruit, and control individuals. This includes when individuals might be introduced to substances or forced to use by a buyer, exploiter, or trafficker in order to perform in a certain way. The actual goal may be to create a dependence or addiction to a substance. It may also really build upon that trauma bond that exists between a survivor and the trafficker or exploiter. There's a couple more points on this slide too, if you want to hit enter. They may also be used to have an individual act in a certain way that could be meeting a demand made by somebody who is buying or controlling somebody for labor or sex. And then sometimes those substances are used as threats or rewards. And among those threats include the threat of withdrawal or overdose. Next slide, please. In addition, in cases of labor trafficking, which can include debt bondage, for example, where somebody is having to work in order to pay off a debt, but that debt is unreasonable and can never really ever be paid off. That debt may include access to substances. It may also be heightened by the use or force to use substances. Sometimes substances are used as a reward or payment. And as I mentioned, they could be used as debt bondage instead. So somebody may be paid in substances and they accumulate a debt based on the substances the trafficker has given them. Sometimes people are forced to manufacture, sell, transport substances in some way. And, this is a longer conversation, of course, but we can talk about the different forms of stigma that people experience when they are being trafficked or exploited and when they are using substances, and how these different areas of stigma start to interact with each other in these areas of harm. Next slide, please. I also really emphasize forced criminality, and this is when traffickers exploit victims by forcing them to engage in illegal activities. And these can include activities of the underground economy, such as prostitution, such as drug sales, manufacture, or possession. This, of course, can create instances in which a victim survivor is then potentially criminalized. They may be taking the fall for the trafficker and may end up in systems which, again, further increase their vulnerability and stigma, while the person who is trafficking them or buying them may not suffer any punishment at all. Next slide. So in order to address these overlapping issues, we received a grant from the Bloomberg American Health Initiative through the Johns Hopkins Bloomberg School of Public Health. And that allowed us to support 4 recent trainings around the state. And we were able to train about 200 plus multidisciplinary participants, which was really exciting. And I've just included on here a few comments that came up in group discussions during the presentations, but really emphasizing here the importance of things that we always know matter in the response to substance use and human trafficking, with harm reduction, meeting people where they're at in terms of their culturally responsive needs, meeting people with respect and empathy and help rather than stigmatizing them, and addressing the barriers that we have to access to services. Next slide. And I just wanted to include this one slide from the presentation, which just kind of shows us the various types of system barriers that people who might be at the intersection of human trafficking and substance use are experiencing. Just the difficulties of getting into treatment, all of the different factors that might affect that treatment. And then the bigger cultural and social factors that are coming into play. Again, about those involvement with systems, that perceptions and stigma, lack of supports. And we did have in some research that was supporting these trainings, some input from survivor subject matter experts. One of them noticed that with so many hoops and so many systems for people to go through, a lot of survivors who are receiving services kind of get lost along the way. They don't access services very quickly. That might lead them back onto doing work that is creating more harm for them and being in harmful situations. So this is a much longer conversation, but I just wanted to include this slide just to show how critically we need to look at our systems and all of the different barriers they put up, and what we can do by working together across our substance use and human trafficking response in order to overcome some of these barriers and create more outcomes for survivors that are positive for them. Next slide. And I just wanted to highlight a few of the key recommendations that came out of the trainings. Of course, we want more education, training, and consultation, and that collaborative work. We want strategies that really get us better access, more rapid access to substance use and harm reduction. And we need more specific types of services that meet the needs of specific populations. We also need to just continue to remove those accesses to care, meet those basic needs, remove some of those barriers that include sobriety requirements and other challenges that people meet that make it really difficult to get into support very quickly. Next slide. We want to see more outcomes in our systems, like justice systems that are specialty courts, diversion programs that are working more with harm reduction programs and not criminalizing people, but actually getting them into services and support. We really promoted healing-centered engagement throughout our training, and this is about creating safe spaces and really building on joy and wellness and support, rather than continuing to only, of course, it's important to work on trauma-informed work, but, also building out opportunities for people to focus on their health and well-being beyond just the trauma that they experienced. And of course, looking at further research, data gathering, and more input from survivor subject matter experts. Next slide. And then, just we really wanted to underscore how important it is for us to de-silo our work, continue to learn from our communities, listen to people with lived experience, continue to evaluate all of the work that we're doing, and always working upstream and focusing on prevention as well as intervention. We spend a lot of time, of course, intervening and providing services and giving different systems responses, but we, could just spend so much more time doing prevention work through education, through comprehensive sexual health education, through building healthy relationships, and other resources out there that can help people be better prepared in order to face some of the challenges that may lead to trafficking, exploitation, and substance use. Next slide. And just some final next steps. We just received word that our partnership with RTI has resulted in a National Institute of Justice Field Initiative Action Research Partnership Grant, which will be starting in January. And this is going to further improve our relationships between our human trafficking and substance use units at MDH so we can continue this work. Really work to look at treatment and what we can improve in those areas, get more data and better data, and just set us up, I think, for future long-term work in this area. So thank you so much for your time this morning. The next slide has my contact information, and happy to answer any questions.
Thank you for sharing. And Erica, if you could put your name, Erica and Krista, if you could put your questions in the chat, we'll get to those after our other presenters, if that's okay. Thank you.
Hi, so I'm next. My name is Cory Cole. I use she, her pronouns, and the title of my presentation when I have 30 minutes to an hour to go into everything is using exhaustive chi-square automatic interaction detection to model intersectional effects on intimate partner sexual violence victimization among adolescents. The title of my presentation when I am sharing a panel with people and need to keep it brief is, next slide, please. How intersectionality theory helped us see the forest, not the trees, and a huge data source. I want to thank Kelly for being the slide master, and apologies that we'll be zooming through these. We have a lot of ground to cover. Next slide, please. So today I'll be making a lot of allusions to a study that my team and I did that was recently published in the Journal of Interpersonal Violence, I guess not that recently, back in January, probably. And we won't really be getting into the weeds on what this study consisted of, just for time reasons, but we'll more be reflecting on the lessons that our team learned from doing this project and the value added that we got from using this methodology, this framework, this mindset to do the work. Next slide, please. Obviously, I'm the one giving this presentation, but I would be remiss not to recognize everyone who had a part in this project, all of whom are listed here. These are some very wonderful evaluators, practitioners, prevention planners, researchers at the Minnesota Department of Health and the University of Minnesota. Next slide, please. So, we're going to talk about real quick how we ended up making intersectionality a key facet of our data to action strategy in the sexual violence prevention program at the Minnesota Department of Health. And, an operationalized part of our strategy rather than just a concept that we're all familiar with, but we keep it pretty separate from our data. And really, what this process started with was necessity. Caused by a large, vibrant, vast data set called the Minnesota Student Survey. The Minnesota Student Survey is like our state-specific version of the YRBS, and it is Minnesota-specific in contents, but Texas-sized. We have over 100K respondents, over 100 questions, and countless opportunities for students to tell us about their demographics, their life circumstances, and, you know, really what they're experiencing on the ground as youth in Minnesota. So next slide. When we got the data back from our 2019 Minnesota student survey, the first question that we were asked to really answer for our partners was, what are the disparities? And we were very quickly able to put together a list like you see before you of some of just like the basic disparities. Of course, all of these are very surface level and they involve a lot of compiling categories into kind of umbrella measures, and the more granular version of this slide was actually a 60-page report going into a lot of detail about, you know, specific groups, specific outcomes, etc. But in its most crystallized form, this is the picture of the disparities. And as you can see, there's a lot of information here, but none of it is quite what our partners were asking for. For example, you see here that students assigned female at birth are 3 times more likely to experience sexual violence as students assigned male at birth. However, most of our partners are not dealing with students who are only a biological sex. They're dealing with students who also have a gender identity, have a racial ethnic identity, have a relationship to socioeconomic status that is very complicated. And so when we presented these results, we got a million questions. Can we see X bullet point broken down by Y variable and then Z additional variable? And, you know, we processed all of these requests. We love giving people what they request from us, but it began to feel like we were trying to light a gigantic dark room by shining a flashlight in one corner at a time or illuminating one wall at a time, when really we needed to just be turning on an overhead light to see the full picture. And we kind of got the impression that when communities ask us, what are the disparities? They're really asking what's happening in my community, which is not the same question. It's just that when you are working in very controlled quantitative data analysis frameworks, what are the disparities is a question that you're trained to translate your real question to in order to get answers. So in order to light that entire room, next slide, please. We looked into intersectionality, which intersectionality is a term that is used to mean a lot of different things nowadays. Like for instance, like it can be used to mean something along the lines of shared risk and protective factor, holistic whole person healing, intersectoral work. In its original form, it had a very specific meaning. You know, specifically, the term was coined by Kimberly Crenshaw in 1989. When she did some very seminal work on how Black women in the workplace experience a very unique form of racialized and gender discrimination. You know, previously to the term being coined, it was spoken about as double jeopardy or even, you know, anti-woman in the 19th century by thinkers like Sojourner Truth, W.E.B. Du Bois, etc. And it really began to crystallize into a full theoretical framework in the latter half of the 20th century. This is a framework that seeks to describe how multiple systems of oppression interact synergistically to create unique experiences of power, privilege, and marginalization, which is to say that each person's experience with racism, sexism, classism, etc., is not just the sum of each of those experiences in a silo. It's something completely different, unique, and something that has the opportunity to be very impactful on a person's health and life course. Next slide, please. Intersectionality isn't necessarily a grand theory, something that is applied the same way in every scenario and every intellectual inquiry. It's more of a lens that you can use to view things. So when we talk about doing an intersectional analysis of our data, we're not talking about the model we use, we're talking about how we choose to think about the problem and how we choose to think about the decisions we make throughout the study. So that involves thinking about our variables not as immutable parts of a person, but how they're interacting with systems. Next slide, please. We were hoping that in public health, nuance and precision could be added from using intersectionality, help us get a little deeper in our data, and not only tell us which people were at risk and how much, but why that was the case. And, tell us what were the forces that are shaping these pathways by which some people are systematically put in harm's way more than others. Unfortunately, because this is a multidisciplinary theoretical framework from sociology, legal theory, et cetera, it is not very easy to translate into biostatistics. For reasons that I can go into later, you can't just do a logistic regression interaction term and call it a day. It takes a lot of background work. Next slide, please. So we decided to test out some of these methods on our Minnesota student survey. Next slide, which, as I mentioned earlier, is gigantic. It's a tri-annual survey of students in grades 5, 8, 9, and 11, census style. So there's no sampling strategy. We just ask every child we can find in the state how they're doing. Next slide, please. There are a few different methods that have been piloted by researchers in the intersectionality realm for doing this kind of analysis in large samples. And among them, we really wanted something that could help us visualize how the risk of intimate partner sexual violence, or IPSV, is distributed across the population, giving us kind of one data point or one centralized thing that we can point to, rather than a million data points in a 60-page report that we expect our community members to look through. We wanted to highlight multiply marginalized groups at exceptionally high risk and identify important combinations of variables to consider in future analyses, especially qualitative analyses and community engagement projects. Next slide, please. The method we ended up using was called exhaustive chi-square automatic interaction detection, which is, there's a lot going on here, but for brevity's sake, I'll just say it's a model that takes a large group with a lot of heterogeneity in it and splits it into smaller and smaller groups until you can kind of get a feel for what's going on in each group at the end. Next slide, please. This is something that one of our co-authors said on a podcast where we talked about the study. I want to emphasize that the complex model is not what made the study intersectional. It is the set of theoretical assumptions that we made when we made each methodological decision, even the really small ones, and the way that we collaborated across disciplines and across different types of expertise to make those decisions. Next slide, please. Some of these other decisions included which variables to include. We really wanted to focus on identities here, used as proxies for a person's relationship with systems like racism, ableism, classism. We didn't end up including anything like system involvement, socioeconomic status, just because we were not as sure about those variables quality-wise as we were about the identity variables. We allowed missing records with missing values on indicator variables to stay, just in case it would help us see, if the missing values themselves were indicative of anything. And we set our minimum group size to 50, which you'll kind of see how that shakes out later on. Next slide, please. Next slide. What the eChade model gives you is a map like this, which kind of looks like a tree, that tells you how your group splits up and by what metrics. So as you can see, the purple group on the far left is our initial sample of about 60,000 students who were asked about intimate partner sexual violence. And all of the green boxes represent end groups or terminal nodes which are groups that could not be further broken down with disparities that the algorithm found. So this is like as close as we're going to get to a homogeneous risk among these students. Next slide, please. We found that of the 20 distinct risk groups, there were groups where only 2.6% of the students had experienced intimate partner sexual violence, and groups where 32% of the students had experienced intimate partner sexual violence. The overall average risk of the entire group was 7.6%. So you can see that it is really ranging a lot depending on who the students are, what circumstances they live under. We observed the highest prevalences in the green box groups that were defined by 2 or more marginalized social positions. So that would be students who were, say, Indigenous and LGBTQ, for example. We also found that inequities operated differently in different contexts. What the model does is that it runs every chi-squared possible at every juncture, and then it automatically chooses to go forward with the one that has the largest effect size that is statistically significant. And we found that what had the largest effect size when you break it down into different populations was very different depending on where you're starting. Next slide, please. Here is just one branch of our tree with some labels that'll help tell you what's going on. And we decided to showcase the heterogeneity within the group of students that is assigned male at birth, just because in disparity analyses of sexual violence outcomes, a lot of times people stop after sex assigned at birth. You know, you think, wow, there is a 3.52% increase in times increase in risk for students assigned female at birth. We don't have to look further at the assigned male at birth students. However, if you do look further, you find that they are not a monolith. In fact, there's another 3.5 fold increase in risk between heterosexual and non-heterosexual students who are assigned male at birth. Among non-heterosexual students assigned male at birth, there is nearly twofold an additional difference in risk between those who are cisgender and those who are transgender, questioning their gender identity. And we are already at a super specific group here of students who are assigned male at birth, not heterosexual and not cisgender. But even that group is not a monolith. We found there is an over threefold difference in risk between students who meet all of those criteria and are white and students who meet all of those criteria and are students of color, which I think just really highlights how much internal variation and diversity is missed within groups when you just focus on between groups. Next slide, please. We were able to look at in our model the within group disparities that were greatest magnitude. We got some feedback from our practice partners not to rank the end groups by their prevalence of intimate partner sexual violence, because our goal here is not to rank the children based on how much danger they face and further stigmatize them, but to really call attention to the forces that endanger the youth in our state. And so we've ranked the disparities within the tree. We found that some of the largest were sexual orientation among AMAB students. Homophobia is a very large driver, structural driver of violence among students assigned male at birth. We found that racism is really powerful in the context of transphobia and especially transmisogyny, like we saw in the previous slide. And we found that, for instance, next slide, please. Single axis disparity reporting really masks the risk of some of the most vulnerable groups and kind of lets you miss some of the ways that variables operate differently in different circumstances. For example, Generally, there is a very small difference between the prevalence that we observe in the Twin Cities metropolitan area and every other area in Minnesota, which we refer to as Greater Minnesota. However, that disparity is actually very large if you restrict your analysis to just students who are LGBT. And I think for any LGBT person who has been to both a rural and an urban area, it's clear why that variable doesn't operate in the same context for everyone. We also found that among the group with the lowest burden, so that was a 2.6% prevalence of sexual violence, 2.6% of several tens of thousands of students is still like a really unacceptable burden of trauma. And we were able to visualize violence that occurs to people who are in that lowest risk group, not as an aberration, but as part of a larger ecosystem of harm that is distributed along structural lines. Next slide, please. There are a lot of different ways we can take this in the future, including expanding our analysis to include not just identities, but also indicators of social determinants of health, even assets, strength, protective factors. There are other methods we can try. Next slide, please. We're really zooming now. I can tell we're running out of time. And I just want to spend some time talking about our takeaways and what we learned from this. Next slide. I think the main takeaway is that intersectionality and quantitative work is challenging, and most of the effort comes in during the interpretation and analysis side. Actually running the model only takes about 10 minutes, but really talking through the results and thinking, how is this consistent or not consistent with the theory of intersectionality, the history and power information that we have about the context we live in and the lived experience of our partners, that takes a long time to work out. Collaboration is essential to this process, especially across disciplines. We talk a lot about silos between topic areas, and there are equally large silos in public health between epidemiologists, evaluators, planners, people who do different job titles. However, all of those job titles and their expertise are really necessary to a data project like this. Intersectionality is very much a team sport. Next slide, please. Oh, no, yeah. There are some tips we have for doing intersectionality analysis qualitatively if you were an epidemiologist working in a public health setting. We have a handout about this, and there are, there are some tips for incorporating this ethos into your work, even if you don't have a gigantic sample size where you can easily recreate our shade experience. So something that you need to remember is that knowledge is power and shouldn't be limited to communities large enough to be stratified a million times. Next slide. We have a lot of work going on in our prevention unit. Okay, yeah, I'm gonna stop. The next slides are vestigial, sorry about that.
Hi, everyone. Thanks, Cory. Boy, your stuff is so interesting. My presentation is definitely the short version, and I just want to encourage anyone who has questions about what I'm talking about or any of the other panelists to just reach out to us directly, either through the MIPA chat today or through our emails. I'm going to be talking about a connection scale instrument that I'm creating. And it's going to be a very brief overview. And as I said, reach out if you have more questions or interest. I want to acknowledge that can you go back, Kelly? Thank you. I want to acknowledge that other people were a big part of this, including our interim director, Dr. Catherine Diamond, John Raisler, Courtney Sarah, and Sarah Wazarek. I'm pretty sure I mispronounced her last name. I usually do, but just so many colleagues helped me pulled this together, and I'm so appreciated I'm so appreciating every single one of them, especially Catherine, because she supports this work, even though it is not funded. It's kind of a side job for me. All right, next slide. So I'm pretty sure for this audience, I don't have to explain why we're interested in connection and community, the effects of connection and or loneliness and disconnection. So we'll just keep going, Kelly. The one thing that most connection scales or measurements have is they're based on self-report. So I was trying to think about how could we do a connection scale that was not based on self-report. One of the very first tasks I did when I started at the Minnesota Department of Health was to do some abstracting of data into the National Violent Death Reporting System. So I know that data set and the suitors data set as well, very well. And as I was abstracting data all those years ago, I was thinking about how could I leverage that data to create a proxy for loneliness and connection. The medical examiners in Minnesota accept jurisdiction of all those cases and they investigate them. The responsibility for finding and defining the next of kin is a statutory responsibility, and the process is standardized. And that's was the whole germ of my idea. Next slide. So this is how the data is flowing. The overdose or violent death occurs, then medical examiner accepts the jurisdiction, they investigate. The data is then abstracted into one of the two surveillance systems, either suitors or NVDRS. And we also have a companion data set in REDCap called Diaz, where we collect data that is either not redacted for various things, or we also collect the data specific to this project, which I'll talk about in a second. After the data is collected and we have enough data to analyze, I downloaded the data, I calculated points and ranks to create an index, and then started analyzing it. The findings and the dissemination is still in its infancy, and yeah, there's just a lot more to come. Next slide. So here are the variables I created basically based on the next of kin search and the investigation that the medical examiner offices do. Here in Minnesota, we do not have a central medical examiner. We basically have 5 unofficial regional medical examiners. The medical examiners are usually embedded in a county, but they also take contracts with other counties. So there's a variable based on relationships of the decedents, whether they were single, if they had an intimate partner, if they had pets, if they were estranged from their family. The medical interaction was whether their people in their lives were directly contacting the medical examiner's office. Did they have roommates? Those kinds of questions. Where was the next of kin located? Did they live with the decedent? Were they local to the area? Were they out of state, out of country? How quickly was the next of kin located, in 48 hours or less? And then there is one variable based on self-report, just in case there is kind of self-report. There's yes, and if the person specifically said somehow that they were lonely and disconnected, then of course that overrides any other variable, because they would know themselves best. Most of the time we have no or unknown information. There's also a special suicide case. This could be quite triggering for people, but I'm going to talk about people who suicide and they have done everything they can to keep their loved ones away from the scene of the suicide. To me and the abstractors who are getting all this data out of the systems, that means they are highly connected. So that's a special circumstance. Next slide. So then based on those 4 variables, I have assigned points based on the answer, and then I assigned ranges for the 4 categories of connectedness. Highly connected, connected, disconnected, and very disconnected are the incredibly fascinating names I gave to my 4 categories, but I wasn't feeling very inventive, I guess. Next slide. And this is how things shook out in my initial analysis. Although I do have more data to analyze now, but I had an N of about 7,800. You can see there the 4 categories and the numbers that went into the 4 categories. I think it's really interesting from this scale that I'm creating is that only 17 of the 7,800 were blank. It's very rare to have just one blank. If one of them is blank, then all of them are blank. And that basically means that we here at MDH could not get any information to put into the surveillance system. Basically, everything's blank. But as you can see, there were very, very few of those. The abstractors here at MDH do an amazing job tracking this data down, collecting it, and putting it into our 2 systems. I just can't thank them enough. Next slide. So here's some initial findings. The point of this presentation isn't really to talk about the findings at this moment, and I'm not going to read these out loud. But basically, you can see here, we're comparing very disconnected to highly connected. We're comparing people who die of an accidental overdose. Then I looked at 10-year age groups to see which ones seemed to be most impacted. The ways you could analyze this data are really probably infinite when you think about it, considering that suitors and MVDRS, which this data is all linked back to, has hundreds and hundreds of variables available. Next slide. So more interesting to me anyway, and I hope to you is, what are we doing with this data? What can be done with this data? What can it help? What policies can it change or affect? What prevention strategies can come out of it? Sometimes when I think about this data, I think about it as this just being a fishing expedition, because through several lit reviews, I could not find another example of a connection scale based on anything but self-report. So I really do feel like with help of my colleagues, I'm just kind of making it up. I'm kind of winging it. So, take that for what it means. I did talk to one of our regional medical examiners, and they have provided me a group to use as a control group, which means a group where they did accept jurisdiction and they did do a next of kin investigation, but they are not a violent or overdose death. So I will soon have a group to compare to, and I'm pretty excited about that. In the future, I want to, as I said, link back to suitors MVDRS and then link forward to other data sets we have through Overdose Data to Action, State Strategy 5. We have the homelessness management system data and some criminal justice data. There could be interesting findings there. Every time I present this to a group of colleagues, I really want to say, how would you use this data? And some ideas I've gotten in the past is to use this to get funding for never use alone lines or safe use sites justifications. I think there are probably other ways to use it, and I'm super interested in hearing anything anyone says about how they would use this data to help forward public health. And then another question I get whenever I'm talking to people not here in Minnesota is, can other people replicate this? And the answer to that is that depends. And I would love to talk to you about it if you're interested in replicating this measurement in your own state. It's always going to depend on your access to medical examiner records and how the coroner medical examiner system works in your state. From the little bit I know about Wisconsin, I don't think it could work in Wisconsin, although I'm not sure. Anyway, thank you so much for listening, and I really enjoyed having a chance to talk to you today.
Thank you, Mary. Thank you, Caroline, Kelly, and Cory. We have about 6 minutes, so let's get to our questions. And so, Kelly, a question that came in after your presentation, wondering if their listening sessions engage lived experience partners and IVP for professionals, or only IVP professionals? Of course, we understand that many IVP professionals are also survivors.
Yeah, great question. Yes, we did our listening sessions very intentional. So we had those that we found to have disparities from our epi data, and we did listening sessions with some of those more prioritized groups. And then we also geographically did listening sessions, knowing that oftentimes we get lots of data more so from the metro, but we wanted to make sure that greater Minnesota was heard as well. So we did a combination. Loss survivors, attempt survivors, and people that have had suicidality, any suicidal experiences were part of that in collaboration with our task force.
Thank you, Kelly. Cory, so we have a comment and a question for you. Thank you for grounding intersectionality in Black feminist thought. People often don't do that, so just a nod to your presentation format. And then also, was there a difference in AFAB students based on sexuality or gender?
Yeah, so we didn't really go into this side of the model, but there was a lot of internal variability among students assigned female at birth as well. A lot of this was by sexual orientation, so we did see higher rates of intimate partner sexual violence among students who are not heterosexual. The model did not have sufficient power to split by gender modality. So cisgender versus trans are unsure among assigned female at birth students, which is not to say that it's not important, just that it didn't have as large of an effect size as some of the other variables. What we found was quite important on the AFAB branch of the tree, but not necessarily the AMAB branch of the tree, was race ethnicity. This is where we really saw disparities among Indigenous, Alaska Native American Indian populations come out. And that's probably rooted in the historical violence and dehumanization towards Indigenous and Native American women in this country. This is also really where we saw the brunt of the greater Minnesota versus Twin Cities metro area coming out. That mainly affected LGBTQP students who were assigned female at birth.
Thank you, Cory, and all of you. It looks like we're in the makings of a 1-hour session for our MIPA training series coming up. So stay tuned for me to be in touch with you about that. And so next for Mary, did you look at relationship of alcohol and or marijuana, THC use to connectedness?
So if you're familiar with the Suiter surveillance system, it does not include deaths that are just due to alcohol use. However, it does collect data on whether alcohol was on board at the time of death for both NVDRS and suitors. So that is one of the many possible analyses that could be done, but it has not been done. The occurrence of THC and other cannabis everything's in the data is pretty low. It could be done, but it's not something we see that often with fatality data from violence and overdose death. I don't know if there would be, I don't know if there anything interesting would come of that. So, but it could also certainly be done. We do have the complete toxicology records on pretty much every decedent. So that is like a gold standard level of data. I hope that answers your question.
And Mary, did you try the data mining approach to your analysis?
I did not. And I love that question. I actually already messaged Nadev because he works here at MDH. This is unfunded work and we're just really short on time. So I love ideas, especially if people want to volunteer to help with stuff.
And so thank you all for joining our session today and the presentations. I have one more question, but before I do that, I just want to do a little housekeeping and say if people need to leave and log off right at 11:30. So we'll break for lunch for 45 minutes. and encourage you to grab your lunch and take advantage of the time to connect with and network with colleagues. You can do this either by connecting with people one-on-one for chats or using the networking matching tool. We also have some exciting MIPA member highlight videos we encourage you to watch. The link for this will be in the chat. After lunch, there will be 2 different breakout sessions with 2 options for breakouts each. You can preview these sessions in advance and you will be able to access the sessions at the start time. There will also be a break in between the sessions to allow you to stretch, network, and make it to your next session in plenty of time. After the breakout sessions, please join us back on the main stage for our closing keynote with Dr. Sydney Timmer Murillo and closing remarks. And I want to check in with our facilitator, see if we should answer one more question or if it's we should start lunch.
I think we can go ahead and answer one question and then we'll go ahead and go to lunch.
Okay, thank you, Heather. To all speakers with large data sets. Oh, I think that was the full question. To all speakers with large data sets, did you try the data mining approach? So I think Cory would be the other to answer that.
Yeah, I guess, and that I would say, depending on what your definition of data mining is, we did do technically a form of machine learning, but I think what you're talking about might involve more looking through text fields for specific strings. And we did not do that just because our data source was mostly binary outcomes.
Okay. Well, thank you all again for being our panel presenters. Thank you all for joining us. Please enjoy your lunch and we'll see you back at 11:30? No, 12:30. My time, I'm Eastern Standard Time, so I'm trying to, at 12:30.